Hi, my dear students. So we're going to finish up our discussion on immunodeficiencies with our emphasis on AIDS as a secondary immunodeficiency. Um, we've already looked at the structure of the HIV virus and its life cycle. So we're now going to look at how it actually impacts patients. We're going to look at its course. How it's going to increase and decrease throughout the time that the disease begins to progress all the way to full-blown AIDS. So there's something called viral tropism, which means that we are discussing what specific types of cells that a virus infects. And we've said this many before, HIV targets CD4 cells, and that's going to be especially T cells, or I'm sorry, TH cells, and also your dendritic cells and macrophages, because they all have CD4 receptors. In the central nervous system, we're also going to see that the microglia can get infected with HIV. So CD4 cells is the main target. Now, when we look at the course of an HIV infection, we can separate it between the actual act of infection and then what happens afterwards during all that replication that it goes through. So you are already familiar with the life cycle of the virus. It's GP120 docking protein needs to dock into the CD4 receptor of a CD4 cell. You already know that, but it somehow must be able to get into the body, and often that needs to happen by penetrating the mucosal surface. You've learned, of course, it can be transmitted differently, but very often it's going to be through sex, for instance, to where the virus needs to get across the mucosal surface, whether it's the lining of the vagina or the lining of the urethra of the male, for instance, or the anal canal even. And then in these mucosal surfaces, we're going to have some kind of an antigen presenting cell, right? Typically a dendritic cell. We might come across a macrophage as well. And they have, of course, our famous CD4 receptors, and they will very quickly pick up the virus. Interestingly enough, some people are genetically resistant to HIV infections because they do not have the correct receptors for HIV. And of course, that prevents the virus from ever entering into any of their cells. So by now, you know how the virus gets into our antigen presenting cells in the mucosae. So you can argue that these antigen presenting cells with their CD4 receptors act as virus reservoirs. And of course, they process the virus and then proudly present the virus antigens onto their major histocompatibility proteins and carry that antigen into our secondary lymphoid organs, whether they're the lymph nodes or the spleen or the Peyer's patches. You know all that stuff by now. So they go, here we are, here is my antigen. And at the same time, the virus is doing its thing. It's going through its life cycle. And next thing you know, all these virions bud off the antigen presenting cell. And guess what they do now? They're in the secondary lymphoid organs. So now the viruses or the virions can go ahead and infect the CD4 cells that are present there, whether they're TH cells or more macrophages. And so now we have major spread of the virus, obviously. And all of this is, you know this by now, is going to be helped out with the help of cytokines such as interleukins and tumor necrosis factor, because they are very good at activating our CD4 cells and keep them going. Now, through time, all kinds of things are going to be happening, and we're going to see that TH levels or CD4 cells, and we're going to focus primarily on the TH cells because, of course, they're going to be our cellular form of immunity. They're going to go up and down at some level, plateau at some point in time, while the virus might also do its up and down. And potentially we might reach full-blown AIDS at some point, which can often lead to death. So we need to go through all these different phases of HIV infection. So we start with the primary infection. We've already discussed that in the previous slides. And then we go through a time period of a few weeks called acute syndrome. Then after that, we can reach the chronic infection stage, which can go for a very long time until we finally start to see our typical beginnings of AIDS symptoms, which ultimately lead to full-blown AIDS and possibly death. So we need to look at all of these in more depth. So this is a graph we're going to use for many of the future slides. I will try to add the graph each time, but as you can imagine, it's going to be in a much smaller size as I try to explain the different phases that we just listed on the previous slide. So as always, it's very important to always point out the different axes of a graph. So I'm going to do that with you. So here we are looking at time. Notice it first says weeks and then it switches to years. And we can do that by adding this break in the graph. So here we're looking at weeks, right? So this is going to be the first few months, essentially, right, after our primary infection. Well, then we're starting to look at months to years. And notice that it can take years before we get to full-blown AIDS. Another important thing to point out is the y-axis, and we are going to look at two y-axes simultaneously. So on the left side, if you have color, you see that that is where your Th lymphocytes are listed. They call them the CD4 plus lymphocytes. So these are essentially your Th cells, right? So that is always going to be on the left side. So that's the amount there. And notice that we can go from 0 to many, right? This number here is going to be critical, and we're expressing it as numbers of cells per cubic millimeter, or the cubic millimeter can be expressed in microliters. It's the same. It's going to be analogous. But we also have a y-axis on the other side, which is going to represent how many copies of the viruses are present. And so you do see that there is going to be, if we focus on the Th cells, they're going to initially drop, then they might reach a bit of a plateau, and then they crash. If we focus on the number of viruses, then we see that initially, of course, with the infection, they are going to significantly rise. But then as the immune system kicks in, they are going to drop drastically for a while. But then, they're going to start invading more and more and more and more of the host cells to the points that they now take over while our Th cells are crashing. So that's a bit of a quick overview of how to interpret this graph. We will discuss each one of the phases. All right, so keep an eye out for these names. The names will not always be perfectly identical, but pretty close. So earlier, we already discussed what the infection is like, right? The virus has to cross the mucosal surfaces, and then it's picked up by an APC. So that's your primary infection, which occurs right here, right, at point 0. But then we're going to move on to what we call the acute phase, which is going to be a few weeks to possibly, longer than that. So during this acute phase, which is especially the first few weeks of infection, because the virus is very successful in spreading, we're going to see in the red, or we're using our right axis now, a very rapid increase in the number of viruses. And correspondingly in the blue left axis, we're going to see that the number of T cells that are getting destroyed increases, which means we see less and less and less of them. But and I should just say T cells, also some of the other CD4 cells, but um, our adaptive immune system is going to recuperate some, and therefore we start to see a bit of a rise as they recover, and we make more T cells, effector T cells. We might even be producing some antibodies. So we see a bit of a recovery period here during that acute phase. There will come a time, however, that the viruses infect more and more and more and more TH cells, to the point that they are also going to get to the TH cells that are memory TH cells. Um, and so that then the struggle is going to intensify. What's interesting, though, is that in individuals that are not treated, we're going to see that the number of viruses is actually going to stabilize around 6 months. Now, the 6 months is not perfectly depicted here, but literally we're going to go into a phase that is referred to as our latency or clinical latency phase, also part of what we call the chronic HIV infection. And this can go on for a very long time, as it says here, can go on for just a few months or many, many years. So here they're illustrating it in the form of many years before symptoms begin to really show clinical symptoms. So as you can imagine, the immune system can't keep up with this, even though the TH cells and the T memory cells were getting infected. The immune system can crank out enough of them to keep up with fighting off the virus to some extent, but ultimately they lose the battle. So um, eventually we are beginning to see symptoms, because the virus begins to take the winning hand here, while our poor CD4 plus cells or our T cells are beginning to go down, 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 and crash. So the phases that progress to what we call full-blown AIDS, we call the progression phases 1, 2, and 3. And we're going to use the CDC method, which looks at how many CD4 cells are present per cubic millimeter or microliter of blood. The World Health Organization uses a slightly different method, so we're not going to touch on that one. So we're going to see phase 1, phase 2, and what's really important here is that once we are below 200 cells per microliter of blood, that's when a person is officially diagnosed per CDC rules with AIDS. This happens much faster in children, by the way, than in adults, this progression. So when we're talking about that progression, we're here, right, where the blue line or our TH cells are beginning to tank. And remember, the 200 level is the point at which a person is going to be diagnosed with the condition called AIDS. So what we're going to now next do is take a closer look at the actual lab results during our two big phases, the acute and the chronic phase. So just a few weeks, the immediate weeks, I should say, after infection, we're going to see that our T cells do crash a little bit, but they do stay above 400 cells per microliter. So here's our 400, and we do stay above that, and then they start to recuperate, right? Despite the fact that our virus levels are still high, our T cells do eventually begin to recuperate. So during this time period, when there are so many virus particles present, as you can imagine, a person is extremely contagious. So then, even a few more weeks later, even sometimes a few months after infection, we get to something called seroconversion. And this is not a term that we just apply to an HIV infection. It's a general term, and it refers to the period, I have defined it right here. It's the period when specific antibodies actually form in response to an infection. And it could be an immunization as well, by the way, right? And that period can vary. So in the case of HIV, it takes a few weeks before we get to that point, and sometimes it can take months. So antibodies are formed against HIV. They can now be detected in the blood. And this is also when the CD4 cell count recuperates some. So we're sort of right around here, right? Where in the blue, those are our T4 cells, CD4 cells, I mean, our Th cells are doing a bit of recuperation such that we're going to see a little bit of a drop in our virus, number of viruses. By the way, that time period between not having antibodies and having antibodies is referred to as the window phase. So now we can start discussing some of the symptoms during the acute HIV infection. Again, the first few weeks after infection, the person might feel kind of fluish, right? Fever, fatigue, headache, even some joint pain, but there will also be some swollen lymph nodes. You know, these are really nothing unusual. If you think about it, when we have the flu, we might have these symptoms as well. But also people develop this rash on their face and trunk very typically. So this is a bit different, this rash. But then when we go just beyond the seroconversion phase, remember that's when antibodies appear and therefore the number of virus particles starts to drop a little bit. I'm sorry, it starts to drop a little bit. I'm pointing to the wrong thing here. Right here, we're going to see that symptoms disappear. And right, we can't see it very well, but there is a bit of a plateau here. We can't see it very well because there's that break in the graph, but we do see a bit of a plateau in this the CD4 count right about here. And so this is that time period of that latency that we discussed earlier. And then it very much differs, can take weeks or months, as mentioned earlier. We finally start to hit those AIDS symptoms, and we're now in that chronic HIV infection where we do see symptoms. So this is towards the end of the clinical latency as we move into the actual symptomatic phase. We now again see fever, but also night sweats with diarrhea. We're going to see all kinds of infections of the mucosa membranes, including the skin. Lymphoid tissue is getting destroyed. And as you can see, our viruses, remember the right side or the red shows how the viruses change in numbers. So we're seeing a takeoff in the numbers of viruses. And little by little, we're going to see that the number of white blood cells are going to start crashing to the point that they go below 400, at which time we definitely say that the symptoms have developed. And of course, by the time we reach 200, a person is diagnosed officially with AIDS. So when we get to the diagnosis of AIDS, where the number of T cells is below 200, we see 4 very characteristic manifestations. There's many more, but these are some of the very identifying for AIDS characteristics. And those are cachexia, certain opportunistic infections, dementia, and then also certain cancers. So let's take a look at these. Cachexia, or the literally wasting syndrome, as you see here in this poor guy, is very, very characteristic of AIDS patient. It's the most significant systemic AIDS system. So basically, regardless of how much these people eat, how much nutrition they take in, they really cannot maintain their body weight, their muscle mass. And it's all due to systemic inflammation that changes metabolic activities in the body, which then has the consequences of not being able to maintain weight. So there's anorexia, there's poor absorption of the nutrients, there's an elevated metabolic rate. So all of these things are making it really difficult for tissues to maintain themselves, especially muscle tissues. Clearly emaciation, there's diarrhea because there's just such poor absorption of nutrients, which leads to very a very weak condition, and it also triggers fever because of all the inflammatory chemicals released. We're going to see all kinds of opportunistic infections by all kinds of microorganisms. And there are some listed here that I'd like for you to memorize, as they are important in AIDS. Like the most common killer of AIDS infectious agent is Pneumocystis carinii, which is going to cause pneumonia. It's a fungus. Um, in the digestive tract, we're going to see fungal infections that can cause candidiasis or thrush. Thrush is that white covering that we often might see in people who develop thrush, for instance, when they're in chemotherapy because they're so immunocompromised. Um, so the Candida yeast is often the major culprit here, and then even parasitic infections by means by Toxoplasma gondii. So those are some important culprits for you, or microorganisms for you to memorize with regards to the opportunistic infections that occur in AIDS. Finally, the very visual features of AIDS, aside from the super emaciated look as a result of cachexia, is also these very interesting dark patches that begin to form on people's skin. And this is due to a cancer called Kaposi sarcoma. It's not really a sarcoma, it's really a carcinoma because it's a cancer of the endothelial cells. Remember, the endothelial cells are the squamous cells that form that simple squamous epithelial lining of all blood vessels. And this cancer can actually all invade the internal viscera as well. Finally, people with AIDS and stage AIDS are going to more than likely develop dementia, or HIV-associated dementia, abbreviated HAD. And what's happening here is that infected macrophages successfully cross the blood-brain barrier. Um, all of our neurons are not fully exposed to our blood because our blood goes through too many fluctuations. There's all kinds of uh, things present in our cells, I'm sorry, in our blood that would possibly damage neurons or cause them to fire too much or not enough. So our neurons in our brain are very protected from our blood. That's not to say that our neurons don't receive any nutrients or anything like that, but there are certain things that cannot very easily make it from the blood into the brain cells. So the capillaries in our brain are much less permeable, let's put it that way, than many of the other capillaries in the body. But somehow infected macrophages manage to penetrate that blood-brain barrier. And as they do that, they can now pass on the little virus particles to the microglia. Remember, the microglia are sort of the are the dendritic cells that protect our neurons and their supporting cells. So now we have infected macrophages, we have infected microglia. They're going to secrete all kinds of weird chemicals that then further damage our neurons and some of our supporting cells in the brain called the astrocytes. And as you can imagine, that's going to have all kinds of impacts, anywhere from a person becoming cognitively impaired. It may also have all kinds of consequences with regards to motor control of the skeletal muscles, so they might become paralyzed or partially paralyzed, all kinds of things, even behavioral changes, so pretty dramatic impact. We don't have a full cure or even a vaccine for AIDS, but we are beginning to get better ways of treating individuals, especially lately. So we do have very good therapeutic management to where people with AIDS can live for many, 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 many years. And we'll get to that in just in another slide, especially. But something interesting to look at now that you understand the life cycle of this particular virus, HIV, that causes AIDS, it's good for you to now begin to think more as a scientist and ask yourself, so how could we possibly prevent the virus from invading and spreading to other cells. And you can then apply that knowledge to all kinds of other viruses or pathogens. So, for instance, remember how our virus needs to be able to use its docking protein to then dock onto the CD4 receptor. So perhaps, and I noticed that I have labeled everything with letters, perhaps blocking that binding um, could help prevent the invasion of the virus into our host cells. We could prevent endocytosis, perhaps. Perhaps we could develop, some kind of a drug that prevents this. We could block the reverse transcriptase enzyme or even the entry into the nucleus and prevent integration of the viral DNA into our own host, into the host's DNA. We can maybe find a way to block transcription or even translation or even block the protein that needs to chop up the proteins that resulted from protein synthesis into smaller peptides to then create our virus particles. And more. There might be a way, and I didn't list that, to prevent exocytosis. So these are just some examples, and I hope you understand them, and I hope you can apply them. And yes, you will be tested on these. I hope this teaches you to be very analytical in your thinking in how we all must reason through how all of these various pathogens work in our body, right? So many, many, many different steps to consider when we want to begin developing some kind of cure or treatment or drug. And of course, each one of these steps is going to have within it 3 million more steps. That makes it extremely complicated to come up with some kind of a treatment. So I think I started my discussion on HIV infection and AIDS by saying we have managed to drastically reduce the deaths due to AIDS because of education. Education is really the most effective way of preventing the spreading of a pathogen. And that's been also very much a key factor in the spread of COVID. Unfortunately, there's still a lot of misinformation there. And of course, together with vaccinations, we can even more so prevent the spread of infectious agents. Now, as I mentioned earlier, researchers have come up with a treatment that is a type of a prophylactic drug, meaning it prevents infections, called Truvada. You might have seen commercials about it on TV. And this is actually for individuals who are negative, who are HIV negative, but they are at high risk for exposure. So perhaps it could be a person who is married to a HIV negative person who is married or is a sexual partner with an HIV positive person. So this negative person, would take the Truvada, and it's been shown to be extremely effective in preventing infection. So this is great. So you might wonder, why do we still not have a vaccine for AIDS? My goodness, it's been around for 40 years now, almost. Well, yeah, 40 years. And a lot of that has to do with the fact that this particular virus mutates very easily and all the time. Of course, really, viruses do that, period. But supposedly, the enzyme that is used to revert the viral RNA into DNA is extremely error prone, so that it makes a lot of mistakes. And for those reasons, supposedly, it's much more difficult to come up with a very effective vaccine. So we're done with discussing immune disorders. Remember, within the immunodeficiencies, we discussed briefly the primary immunodeficiencies, which can be due to problems with the innate immune system. We did not discuss those in any detail, those problems. We did look at some examples of deficiencies in the adaptive immune system. And we distinguished between primary B cell deficiencies as well as primary T cell deficiencies. And then we also looked at the very severe type of immunodeficiencies where both arms of the adaptive immune system are affected. Most primary immunodeficiencies are inherited, or they spontaneously develop and create develop, as in we see the mutations as de novo mutations, so brand new mutations, very often already present at birth, so they're congenital. And then we have acquired immune deficiencies, which are going to develop and therefore acquired later in life. And we chose as our main example AIDS. Secondary immunodeficiencies can result from invasions of pathogens such as AIDS, but also due to environmental factors, drug abuse, poor diet, etc., etc.